I'm absolutely delighted to welcome Dr. Tasnim Binta Azad, who is working in Bangladesh. She's previously project coordinator, the International Organization for Migration. Now, Tasnim is going to bring us a really important perspective, and that is from working on the ground in an example of integrated care. This is something we'll do every single webinar. Tasnim, it's lovely to have you with us and for you to be our first speaker sharing from Bangladesh. Thank you so much.
Thanks, Moira, ma'am. Welcome everyone once again. Yes, this was my project, Palliative Care in Bangladesh, and this was the very first time I started working with palliative care and in Cox's Bazar. You could see, if we think about what's going on in Bangladesh, then we can think about what was happening in Cox's Bazar. And while I looked at the national data, there is estimated 600,000 patients in Bangladesh who need palliative care each year. And 200,000 patients were diagnosed with cancer. When we talk about palliative care, is coming up with cancer and other diagnoses, also terminal illnesses. And in a stage, Bangladesh is now, from the practical experience, close to 80 to 90% of cancer patients, while they are visiting the health centers, is like they are already in incurable stage. Before I started, I was lucky to get people, many of them are present in this webinar. They did some initial palliative care works in the Rohingya camp. It was done a need assessment. A need assessment in November 2017, right after the influx. Some of you might know that the influx was in August 2017. And after that need assessment survey, there was development of a small home-based care. And it was led by a national palliative care consultant, Dr. Farzana Khan, my mentor and my supervisor, the very first one with whom I started to know about palliative care. And only with 2 Rohingya volunteers, community health volunteers, she was doing that door-to-door visit and providing that palliative care services. And it was close to 1,000 patients that the team reached. After that, in February 2020, IOM took over the project from Fasiuddin Khan Research Foundation. Like all other programs, we had many challenges, and some of them are still ongoing. The major challenge was and still is existing, not like very strong like previous. That time we started working, it was like the understanding of healthcare professionals about why palliative care is important. Second one, we started in January 2020, and you know, in the whole 2020, we had problems with COVID. So in-person training inside the camp during COVID was a real challenge. Use of morphine, I was hearing Dr. Catherine's presentation that use of morphine and the controversy. Bangladesh is not beyond that, and inside the Rohingya camp, it still is difficult to think about whether we should use morphine or not, how the healthcare professionals see it to use morphine. And not the last, but a very important one, that while we worked with palliative care, it was a sense from the other healthcare professionals that one team is dedicatedly working for palliative care. So why we are not sending the patient directly to the palliative care team? And initially I was informed, I was told by many professionals that this is not the place to do palliative care. Definitely this program will not get many patients. This is the data from January to September, how many patients we served by our small team. We served almost 6,000 Rohingya populations, among whom 1,000 patients was actually Bangladeshi, the host people. I often get questioned that we were working inside the Rohingya camp, and how do we get patients from the host community? And it is still unforgettable to me that I heard some comments from people that they traveled to the Rohingya camp, the Bangladeshi people, and some of them are saying that we heard there is a small team who is working with people, those who are already incurable diagnosed, and it's very harsh that we heard there is nothing can be done for us, but still one team is working here. That's how we visited, and the number is 1,000. How we identified, definitely we followed some of the guidelines and resources available online, and we got many guidance from our project lead, Dr. Farzana Khan Madam. But initially what we adopted from the triage station, our nurse, the palliative care nurse, used to visit the triage station. Even the nurses who were working in triage station, we used to talk with them that if you get any patient who is having life-limiting illness, you can send the patient to us. And we started with capacity building for the healthcare professionals. And later on, we were getting so many phone calls from different health professionals, and they were asking for the symptom management advices, sometimes to send the patient to us, but it was always confirming before sending the patient to us. So it was kind of over confirmation. And second one, we looked at the home-based care. Our palliative care assistant used to visit door to door to see that if there is any individual who is suffering from serious illness. Before we started our field activities, we trained the whole team by both national and international palliative care experts, and we were lucky to get 2 World Cancer with us, and a few of our team members already got training from 2 World Cancer. And from that side, with ECHO programs, we got a very strong network to ask for help. And that what we have to do when we have really limited resources, and that's the very first and the only program existing in that area. What helped us? The list could be very long, but in short, definitely the capacity building training to make people understand why it is important. Another one, we looked at the community-based approaches rather than the facility-based one. And we got continuous guidance and support from our project lead, who is a national palliative care consultant, I said before. And last but not the least, very important, but we were flexible. I think the team is still flexible to adapt different situations, which made them stable. I will share one of my story. We got one patient in the Rohingya camp who came to our PSC in November 2020, and the patient was 80-year-old elderly male, and he complained, just one complaint, that he is having difficulty in breathing. And while the triage nurse sent the patient to our room, our corner, palliative care corner, it was something that very foul smelling is coming, but we could not see anything visible. And while the nurse approached to the patient, we saw one cotton clothing over his neck region. It was tightly tied over the region. And while we opened this, we got a non-healing ulcer, very ugly looking, having excessive amount of foul smelling from it. And according to the patient, he was good 9 months ago, and suddenly he developed an ulcer over his right side of the neck, and gradually it was getting worse. And very next day, while we asked what happened, and very next the patient attendants came with the previous papers, and they were saying that we're happy someone is asking, because previous time wherever we went with this paper, it was like nothing could be done. According to our findings, we did the local examination, and we got the confirmed diagnosis was a squamous cell carcinoma according to the histopathology report. And we tried to do some medical management that time while we got that patient. We tried to do the wound care dressing, and the pain management was also done. And for breathlessness management, we tried some positioning, as in this stage we can't think about sending the patient or referring from the camp, so many other things was not possible. And we scheduled something initial visit. After the initial visit, we tried the follow-up visits and also the home care visit by our palliative care trainers. And other than the medical management, we shared our phone number, that patient and his family had a sense that there is something that we can try, we can call, we can communicate with them. And we make them understand what to expect according to this diagnosis, what could be done from our end, and what they will expect. And we got some comments from the patient. The way we started, we had no idea what we can do, but still there was something to offer, and we offered. And patient said thanks to us, and it was from his side. The comment was, I don't feel that much breathlessness because I'm not squeezing that cotton clothing over my neck anymore. And they got room to share their physical and emotional things without hiding themselves inside the house and not visiting the healthcare centers anymore. I would say it wasn't easy for us to think about palliative care, provide palliative care for this 900,000 Rohingya community. And in general, although we say one palliative care team, but I worked as a program manager there, and we had one medical doctor, one physiotherapist, and 4 nurses to work there. We had no idea about our job contract. During COVID, it was told that they will only look for the essential cares. And I was the only one that time went with the SPR guideline and said that according to the humanitarian context, according to the SPR guideline, palliative care is essential care. So there is no means you can stop us right now or you can keep it paused. I don't know the way we started, it is successful or not, because that could be something very relative. But for me, it was sense of purpose. End of the day, we felt like, yes, we are trying our very best to do something. I tried to make all my colleagues and healthcare professionals, and for myself also, both are important to alleviate suffering and to save lives. We can't judge one by another. And if you want to hear more about our works, we have a story from IOM, what I said and what we did as a team there. You can see the YouTube link here also.
Thank you so much, Tasnim. Thank you for sharing that incredibly moving story. I think what was coming through to me certainly was the humanity of what you're doing and the dedication. You told me before that someone says, why is a young doctor like you involved in palliative care? And we're delighted that you are, and for sharing with us.